I'm happy that everyone's here today. This is the first year that we have opened up this health system forum to interested health systems that are outside of our partners. So for those of you who are joining for the first time, welcome and thank you for being here. We hope you will find the forum stimulating and useful. Today's sessions will be recorded and made available in the archived events on Learn's webpage. So, please share this information with colleagues who may not have been able to make it today. I'd like to, first of all, acknowledge and thank our funders, the National Center for Medical Rehabilitation Research and the National Institute on Nursing Research. I would also like to thank our Forum Planning Committee, who helped develop this year's Health System Leadership Forum agenda. Thanks to everyone for their help. Next slide. It is now my pleasure to introduce Raj Srivastava. Dr. Srivastava is a Senior Medical Executive Director of the Healthcare Delivery Institute at Intermountain Health. The Healthcare Delivery Institute is a center for education, implementation science, and applied health services research. Within the Institute, Dr. Srivastava leads Intermountain Health's Implementation Science Core as a professor of research. He also oversees the Advanced Training Program in Clinical Quality Improvement, an in-depth course designed for healthcare professionals who need to teach, implement, and investigate quality improvement, outcome measurement, and management of clinical processes. Dr. Srivastava co-directs the Stanford Intermountain Population Health Fellowship Program, which takes advantage of the two institutions' synergies in research and system implementation design, and their strong desire to deploy effective evidence-based interventions. Dr. Srivastava is a tenured professor of pediatrics at the University of Utah in the Division of Pediatric Hospital Medicine and is a practicing hospitalist at Primary Children's Hospital in Salt Lake City. He trained at the Hospital for Sick Children in Toronto and at Children's Hospital, Boston, Harvard Medical School. He is past chair and current advisory board member of the Pediatric Hospitalist Research Network, PRIS, which stands for Pediatric Research in Inpatient Settings. Dr. Srivastava, welcome. We're really looking forward to your keynote.
Thanks so much, Dr. Freiberger. It's a real pleasure to be here and really exciting to talk at the Learn Forum. This relationship partnership is highly valued by our organization, and I know we have a lot of leaders at Intermountain Health who participate, and it's great to see the other sites as well. So I'm going to be speaking about how learning health systems can really do the job we've set out to do by following the data. And so hopefully that as we go through it, you can see that theme come up, and then we can talk about it as well in the questions. I think, especially in the American healthcare system today, people really want to be well cared for and have healthcare accessible in the way they need it. So I want you to imagine you are the parent, or you have a child that is close to you, and they sort of are running around the playground, fall down, bonk their head on the concrete, and you're wondering, is everything okay? Or you might have a loved one that has suffered a stroke, and they're on their way to the ER, and you're worried about what's going to happen. Or, for example, somebody you know is super sick, or you might be super sick, and you end up in a hospital, and you're in the intensive care unit, and you actually need an artificial breathing machine to help. What would you want to have happen to you or your loved one, or basically anybody who really needs the help that we can deliver? So I think what people would want would be to get that care that they know is really providing the high quality that they deserve. So I'm going to go through a little bit of a journey at Intermountain, how we have really focused on the data to help us get there. And then at the end, wrap up that one slide I just showed you about what would you, how would you want to be cared? So Intermountain Health we call it Intermountain Health now. It used to previously be called Intermountain Healthcare. Changed our name to really focus, I think, on um, the value-based care that we are trying out to get to prevention care in our organization for the populations we serve. And I know many or all of the health systems that are part of this and others who are joining, many are on that journey as well. At Intermountain, we have a integrated healthcare delivery system, which means we have all these pieces that can connect theoretically in a smooth way to deliver amazingly high quality care. In addition, Intermountain, we have a health insurance plan. That health insurance plan was started in a very unpopular time in American history in the 80s. Intermountain lost tens of millions of dollars each year for a long time. Fast forward, we're now in a world of value-based care, and our health insurance has about 1 million people that are paying in order to get their care up front and keep them healthy. So that really changes the nature of our system. All right. So what we've really focused on at Intermountain is I work in the Healthcare Delivery Institute, and we know that there's things that should be done, but the famous line many of us use is it takes about 17 years to get out there into practice. What we do here in the Healthcare Delivery Institute is we're a team that partners with the clinical teams to say, how do we get from that evidence to the bedside? And that is really hard to do, but that's what I'm going to walk through that story of how we're doing that. And data is actually instrumental to do that. The model we use at Intermountain is called clinical best practice integration. Clinical integration is a term commonly used about how you bring pieces of the clinical side together to really help deliver care. And we are focused on best practices. In our model, we believe when we follow the model, patients' outcomes are improved. And I'm going to try to convince you of that. So clinical best practice integration, or CBPI for sure, try to use the full term. We are like every other health system. We want to spread evidence-based best practices. So on the left, we have ways of spreading evidence-based best practices in the physician side, nursing side, respiratory therapist side, pharmacy side, rehabilitation medicine side, physical therapy side. Everybody knows that they have best practices. So we all spread them. Occasionally, like every other system, we feel the electronic medical record and technology can help nudge people in the right way. That's what's indicated here in this amazingly fuchsia color, I think. We use technology to do that. And then sometimes we want to measure how the team's performing in every instance of that patient's care for that best practice. When do we do that, and why do we do that? Well, we do it when research has told us if the teams follow these processes of care, that patient will get a better outcome. And we do it because we don't always need to just track the outcome, because sometimes it takes a long time to track the outcomes, or the outcomes are years from now, especially when I think about some of the rehabilitation outcomes. There are some short-term ones, but there are some long-term ones. However, we do know there's pretty good evidence. We got to get the teams to do that. So let's actually figure that out. How do we enable that as busy as everybody is? So here's the clinical best practice integration model in a nutshell. It's got 5 steps. 1, we want the clinical teams to figure out what are their potential evidence-based best practices that they have. Turns out every group knows these. Societies put them out. People talk about them all the time. They're published. Some people sit on committees. So let the teams find them. Secondly, and this is a hard lesson learned for us, we distill that evidence-based guideline into 3 to 5 key leverage points. What are the 3 to 5 things we need the frontline teams to do reliably? Third, within that step, we also certify the evidence, meaning Was that multi-center randomized controlled trials that have shown this, which is kind of the highest evidence we have? Because that's really important when we're thinking about resourcing something like this across a large health system. Third, we create a measurement system. I'll show you some examples. That measurement system has to measure the team performance by what they need. If it's by hour, because it's an ICU, if it's by shift, if it's by location, if it's by specific provider type, we need all that information. So that's the measurement system we create. All of that is one big piece to do the next thing, which is we then want to understand our current state performance and define our ideal state. And then we pilot to drive to higher adherence. By how do we do that? We actually want to understand the barriers. So we spend a lot of time with the frontline team learning what those barriers are. Then we use implementation science strategies to we try them in pilot, and then we spread them to the rest of the sites. And then lastly, sustain. I have yet to go to a health system that somebody hasn't said, well, I worked on that, and now here I am X number of years later, and we're kind of working on it again. I think it's our opportunity to say, let's not waste the gains. Let's actually design a sustain model that works. How can we monitor performance and just detect when people are drifting from that performance and help them go in? With today's healthcare challenges, which are pretty plentiful, sort of rapid turnover of staff is a big one. So how do we train people? Because maybe that's one of the reasons why we're drifting. Okay, we put all of this model in a pipeline. We have all of our clinical areas at Intermountain have their own pipeline. So the emergency department has a pipeline, oncology has a pipeline, musculoskeletal has a pipeline, rehabilitation services has a pipeline. Why do we need pipelines? Because when the pipelines meet is when two groups are going to try to cross disciplines and say, we got to do that for the patient in this moment. We got to get to agreement, and we got to resource that and measure how we're doing that. So that's really important for us. We also love technology like everybody else, but feel that the current technology is not actually made to help the frontline provider. So we need things to adjust that. And we have different steps we can use with our technology partners in order to really enable frontline care to be a little more seamless than it is today. So I have a few clinical examples. I'm only actually going to focus on one, and that actually has to do with adult stroke. Thought I would walk you through the model, this model that we have worked on different iterations of things at Intermountain Health of how we spread best practices. And this one has actually been live and still is live today since 2018, and actually being spread to our larger footprint. We're like the 10th largest not-for-profit health system in the country. And so our challenge is, how do we take that to other areas that haven't been doing this before? So I think this was that scenario 2 that I talked about at the beginning about what if somebody you knew or a loved one was having a stroke, what would you want? So here's a woman who came into one of our emergency departments, and online you've got one of our neurologists who's providing care using telehealth. So here is walking through the pipeline. So first of all, the neurology team said, hey, there's a really good evidence-based guideline that's actually been known for a little bit. And it tells us exactly what should happen when somebody rolls into our emergency department and we think they're having a brain attack or they're having symptoms of a potential stroke. This is what we've got to work on. So somebody had done that. So when we worked with the team, we said, what are the 3 to 5 things you need the teams to do? Number 1, they need to get this clot-busting drug in less than 60 minutes. That is the key leverage point that has been shown. If that happens, the patient's outcome are going to be the best they can be. Number 2, they need to get a neurologist to help walk this through in less than 10 minutes. And because we live in the Intermountain West, we don't have neurologists at every doorstep. I'm not sure there are enough neurologists in the US to go around, but we had to use teleneurology in order to do that. The third thing they said is, hey, by the way, we kind of need to know if it's a stroke, and we need to know it's not the type of stroke, which is only like 15% of the cases, which is a hemorrhagic stroke, meaning they're bleeding, which means this clot busting drug is only going to make that worse. And there's some other indications we shouldn't be doing it. And so nobody wants to accidentally do that to a patient. That means they've got to get the CT scan when they hit the door under 15 minutes. So they laid these out and talked about the reasons why that was really important. And so then they built a measurement system. I'm showing, and I know somebody raised their hand, but if you wanted to put some questions in the chat, I was hearing we can address those, and we have plenty of time for that. And we can even go back to the slide if you want. I thought I would show some ways that we use data carefully curated by our amazing data analysts who are kind of the lifeblood to this work, working with the clinical teams in order to understand how are we doing with each patient, and then rolled up how are we doing at, say, that particular emergency department level, or how are we doing at the 23 emergency department level. And our data is incredibly helpful in order to understand current performance of how we are doing on those, say, 3 leverage points, and why are people having challenges so that we can work through and help them do that. So the steps we took with the team once they built the measurement system, and we got a really decent understanding of current state performance, was we went to the sites and we said, we're going to try pilots. So 3 emergency departments said, hey, we want you to help us with our potential stroke patients that are coming in the door. We also had senior leadership understand this was a project we were going to do at the system level. So we needed to prioritize how are we going to set this up for success. And priorities in health systems, I don't want to get off on a tangent. That is a tough thing to do, but we had achieved that. The third thing we did was say, we're going to need a local champion at each site. And that local champion might have to be a neurologist, and it might have to be an emergency department, and it might have to be a nurse in the ED. Why? Those are the people who are going to know their colleagues, understand the local things that are happening in their emergency department. It might be different than the emergency department 10 miles away or 200 miles away in our case, because even though we're under one system, every place is a little bit different, has their own culture. So we needed those local champions. Fourth, we set out a very deliberate communication strategy to understand what was happening, educate people, train them, and close the loop on their performance. That closing the loop, by the way, started off where we would say at the end of the quarter, hey, here are all the patients with stroke. Here's all the data. Yeah, you can filter all the stuff you did that got it under 60 minutes. Here's some that are over 60 minutes. What happened? What do you think they said? Well, why'd you take them so long to show me the data? Well, how long do you want to see the data? We want to know within 24 hours. Great. So then we could roll back the measurement system to say, that's how we're going to get it, because you kind of almost need to catch people at the end of a shift to do a debrief the next day to kind of understand what all the barriers were. So we didn't start off, our measurement system had to grow with what we were learning in our pilot. Then fifth, and I've talked a little bit about this, and that's the theme of this forum, is we needed consistent measurement, trusted data that the ER providers, docs, nurses, advanced practice providers, neurologists, everybody who was in this had to believe it. And so that's why we built that consistent measurement system. So how did we do? Prior to us doing something, piloting in 2018, 2016, 2017, our neurologist said, Raj, we've done a lot. We've hired neurologists, we put them in teleneurology, and we still can't get below 60 minutes. So we had already created that investment. We thought it was a workforce issue, but that wasn't exactly what was happening. So then we started the pilot in 2018. We actually started it in the last half of 2018. And those three emergency departments were deploying things for 1 quarter. It took us 1 quarter to get set up and then 1 quarter to try. The times were so short in that last quarter that pulled the entire system median average down below 60 minutes for the first time in a long time at Intermountain Health. So only 3 ERs doing something for a quarter. The year after, and this is when I was a little skeptical of the team, my team was like, we're going to scale this to 20 other EDs. And I was thinking, well, I've been doing this for a long time. I'm not sure how you're going to scale it exactly. Turns out they did. By the end of the year, all 23 EDs were using this model. And look at the time, 52 minutes was the median door to needle time. 2020, year one of the pandemic, nobody was, even though we knew patients were coming in with so many problems with COVID and we were all learning as a world of how to deal with this. And, people were avoiding us for a period of time. Then people were coming in, and we know there was a little bit of increased risk of neurologic things with stroke. I talked to my ED friends who tell me it was a brutal year. They didn't miss a beat, though. Within Intermountain, the stroke care was even a little bit better. Okay. So what's happened in Sustain? Raj, that's 2021. What's happened in the last 3 years? Turns out we are still achieving the goal we set, that more than 85% of the patients across our system are getting this door to needle time in under 60 minutes. And here's our data. This is 2022. I have 2023. It's a live dashboard that we actually have that still shows this. And you can see here that best in class care is it should happen 85% of the time. And we have achieved that in 2020, 2021, 2022. Okay, so what's the clinical impact? 23 emergency departments are getting the door to needle time 12 minutes faster. Each minute, there are so many neurons that die if you're having a stroke. So 12 minutes really matters for brain function and all of the residual effects that happen afterwards. We piloted this model, the stroke model, in 6 months. We scaled it in a year, and we've been sustaining it since 2020. So 2020, 2021, 2022, 3.5 years. It's still the way we practice. So if you want to come to Utah and you want to go on a hike and you're in rural Utah and something's happening and you're worried you're having a stroke, roll into one of these EDs and you're going to get this door to needle time. That's going to be the best in class, I think, that we have. Okay. So that's the stroke example in the upper left. We actually have used this model in other areas that have also come through and also piloted, scaled, and sustained and are still live today. And I think really helped us figure out how to shorten that time of knowing something and then getting it to the bedside. In our healthcare delivery institute that I have the pleasure of working in, we have a lot of different ways we can help promote this model to really ensure it's delivering patient outcomes. And one thing we do actually is we have a class called we educate people. So we have a class called the Advanced Training Program in Quality Improvement. Some of you may have taken this or heard about it. It's 33 years old. I have not been teaching the class for 33 years. I've been teaching in it for about, 11 years, but I became the course director 3 years ago. And 3 years ago, we realized we needed to focus on a couple of things. The value story we're trying to explain in American health systems, that why we're on this patient journey with patients. And then number two, we really need to explain models that you can take your care and get it across a whole system and sustain it. Because that's why we all focus on quality improvement in our organizations. So we have this is sort of the course curriculum, and we've just kind of designed it to help people say, if you can go through the cogs, you can get to the end of the row. We actually have cohorts number 133 who just started 2 weeks ago, and cohort 133 is graduating next week, and 134 is just started last week. And the class is actually open to internal and external people. In our merger, what we did as a health system was we actually, because we merged and we have a larger footprint, our chief clinical officer and our chief medical officer said, hey, Raj, can you help spread the clinical and cultural integration that's going to be needed for success, and just see if we can try this. So what we did was we actually said, hey, is there a problem in healthcare that's so big that any one discipline can't solve on their own? Turns out there are many. The one they chose, though, was low back pain. So we invited 45 of our health systems leaders, rehabilitation specialists, physical therapists, primary care physicians, neurosurgeons, the insurer, data analysts, our technology friends. We invited all of them to take a special advanced training program. In the history of our organization, we've only closed the class 3 times to external people. This was one of them. And in the spring, they all came, learned these skills together, and came up with 9 projects to help along the continuum of low back pain. How do we avoid patients getting unnecessary imaging and opioids and ending up in surgery if they are really like the 9 out of 10 patients that could do just as well if they got physical therapy early? How can we try that in our system? So I'm really excited. Next week they're going to be presenting their projects, but to me, I think bringing in a multidisciplinary team to focus on really tough problems are kind of the things that patients want us to be doing and figuring out better. So we're kind of excited about that. And then our class is open for anybody who wants to maybe peruse it or take a look just to see if this is something that they're interested in considering. And I know there are actually a lot of people in this forum whose leaders have taken this in the past. I did want to acknowledge the amazing work our rehabilitation services at Intermountain have been doing for a long time, and walk through, as I have sort of seen the org unfold, that group of therapists have banded together to say, wait a minute, we had a question. We work at Intermountain. How good is physical therapy? How are we doing on what we know? And that's something that was kind of done 20 to 25 years ago. There were a couple of leaders that came up, Gerard Brennan, Stephen Hunter, and others. And what they ended up doing was they just collected data at 5 outpatient PT sites. Then they ended up creating a database, and they standardized the measures. They were evidence-based, which was amazing, very forward-thinking. And they were measures that could be done if the army of physical therapists could agree that these are the ones we wanted, when did we want them, and in which patients. And so that's something that they'd been building, and everything was done by hand for about 8 years. Until then, they rolled it into an electronic system, and then it's just been growing ever since. We within Intermountain now completely rely on those leaders who had done something 20, 25 years ago and can do studies like the ones you see on the right. What are the outcomes of people who have total knees done? And what was their baseline function? And what happened after they got surgery? And what is their time of recovery? And you almost have like this operational system that you can kind of dial in and see who's getting better and how might you deploy resources, including PT resources when they need them, and or have a base model for PT post-op, but then adjust it for certain patient populations if things are backtracking. It's an amazing thing to watch. And so their papers that Kate Minnick and colleagues at Intermountain have published on recently, but I sort of see this incredible organization focus on data, and the clinical folks kind of drive how's that really going to work. So I think I would just end by saying we're like our health system is probably like a lot of other health systems. In our health system, I think we're kind of lucky that we've had, just like many of you, giants who have done amazing things. And really our focus is to help people live the healthiest lives possible. And I know every health system has their own mission. I kind of think that's what patients in the communities that we serve just want from us every day. And so to me, I think the answer to the question, I'll just give you the answer, especially because everybody's on mute and we've asked you to wait for questions at the end. I think if I had somebody or one of my kids a long time ago when they were young, or somebody loved one had a stroke or needed mechanical ventilation, I just want them cared in a system that's a learning health system. Please, I want them to know they're using the data so that they can actually provide the highest quality evidence using what they have. So with that, I will end there and see if people have questions.